Please go ahead.
Welcome, everyone, to the ERS webinar on current challenges in ILD. We hope to be able to update you on your knowledge in this upcoming agenda of interstitial lung diseases, not only on progressive fibrotic phenotype, but also with the impact of SARS-CoV-2 infection in pulmonary fibrosis, and finally in home monitoring in interstitial lung disease. So welcome, and welcome also my dear guests, Maria and Marlies. I will introduce you later on. I will give now the floor to Marlies Wiesenbeck.
Thank you, and to be very brief, because I think our first speaker, Carlos Gordillo, doesn't need any introduction because all of you will know him. He's the ERS Vice President, but besides that, he's also a very distinguished pulmonologist in the Coimbra University Hospital, and he's going to give us a talk on the update on progressive ILD. Carlos, I'm looking forward to your talk.
Thank you. So now I'm ready to start. So my talk will be on an update on progressive fibrotic ILD. Those are my disclosures related with this presentation. And so what I would like you to know at the end of my talk is the need of looking at clinical disease behavior in order to identify, to an early identification of potential patients that can have a progressive fibrotic disease. So I think maybe the first approach of classification based on disease behavior was on this paper of the update on idiopathic interstitial pneumonia published in 2013, where at that time we divide the patients into the reversible behavior, stable behavior, or progressive behavior, namely with an irreversible disease. And at that time, IPF was the main scenario. Yet IPF is a disease, as you are all perfectly aware, with overlaps with other forms of progressive fibrotic diseases, sharing pathogenic mechanisms and sharing also clinical disease behavior. This is a survey supervised by Marlies in several European countries, where we can see a prevalence of autoimmune lung disorders and also NSIP, unclassifiable diseases, and HP, so hypersensitivity pneumonitis, in this group of non-IPF interstitial lung diseases. And this is an example of a patient that have progressive fibrotic interstitial lung disease. We can see here apical and basal images at baseline, 36 and 42 months after. And in these images, we can see an upper lobe predominant lung fibrosis. So meaning that these progressive fibrotic entities, it's not only UIP. So this is not only basal predominant lung fibrosis. And independently of the initial insult to the epithelial cell, under a pathophysiological point of view, it can be seen at some point a common evolution. So a trend to a recruitment and activation of fibroblasts, an excessive extracellular matrix deposition, and so leading to a self-sustained lung fibrosis independently of where the entity came from. So what we normally use and where we can base the definition of this progressive fibrotic ILD is on the eligibility criteria for clinical trials in this scenario, not only in which concern the decline of lung function, also the worsening of symptoms and also the increasing of pulmonary fibrosis in CT features. So, but anyway, we can see that there are different time frames in this definition: 6 to 12 to 24 months. First of all, secondly, different percentages of decline to consider this definition: 5 to 10, or between 5 and 10%, and also different situations looking at the absolute or the relative decline in lung function. So at the end, what I would like to tell you is that a more pragmatic definition of progressive fibrotic ILD is needed. Those are the entities that are considered among the interstitial lung diseases to have a potential of a progressive fibrotic disease, not only IPF, NSIP, IPAF, unclassifiable diseases, also some connective tissue like rheumatoid and systemic sclerosis, hypersensitivity, pneumonitis with fibrosis, stage 4 sarcoidosis, and some occupational exposures like asbestosis and silicosis. And looking at the diagnosis of these entities, this is sustained on the normal workflow that we always use to diagnose interstitial lung disease. So clinic function, imaging, and many other data. And to come to or a final diagnosis, or a working diagnosis, or a situation where we cannot classify these patients. And what we have to monitor in this whole scenario is the clinical disease behavior with the fundamental role of the multidisciplinary team discussion, in order at the end to identify the potential disease progressive patients. Regarding treatment, it's important to look at this trial. So the inbuilt trial, nintedanib in fibrotic progressive interstitial non-IPF diseases, where you can see here in the demographics that almost 40% of the patients had a non-UIP pattern, and that there were different criteria used for the definition of disease progression, only based on function and symptoms and the extent of fibrosis in CT, or only in symptoms and in CT features. And also, in this study, almost half of the patients were patients with autoimmune interstitial lung diseases or hypersensitivity pneumonitis. And what we can see with this summary of the results is that there was always a benefit that was, these studies showed always a benefit in the usage of nintedanib compared with placebo, independently of the UIP pattern or in the overall population. And here you can see on the right side of the slide the difference between the nintedanib decrease in lung function and the placebo decrease in lung function. Continuing with treatment now with usage of pirfenidone in unclassifiable disease, this is the most important study and publication where we can see that the primary endpoint was not achieved. As you can see, it is not a positive result in the primary endpoint, and this is due to technical issues based on the ohm spirometry, and so the difficulties in applying the planned statistic model to this primary endpoint. Maybe we can discuss this after Marley's presentation, because I think this is more important to discuss this at the end. Otherwise, we had positive secondary endpoints, based on the FEVC measure on site and also on lung diffusion and on 6-minute walking tests. So at the end, we can see that 24 weeks of treatment with pirfenidone showed in this study a slowing disease progression compared with placebo in these patients with unclassifiable diseases other than unclassifiable idiopathic interstitial lung disease. So coming back to the diagnostic and also to the management algorithm, I think it is important to look again now in the light of these last results I show you on the important focus on the identification on patients that can have a disease, a progressive interstitial lung situation, namely, and in order to identify the patients that might be suitable for antifibrotic treatment. So this is quite important for this algorithm of the decision, diagnostic and management decision. But we can be more precise. And with this monitoring, we can look more deeply in these entities and divide the disease into mild disease, moderate disease, or severe disease. So a mild disease with lower decline of lung function and other patterns than UIP, an intermediate situation here, and here more severe decline of lung function in UIP pattern. And so the management is different. Here we can stay on the smoking cessation or removing offending agent in the intermediate situation, looking for the fundamental multidisciplinary team discussion, but essentially to the possibility of introducing immunosuppressive therapy and the more severe diseases, also looking at the multidisciplinary team discussion to consider antifibrotic therapy as first-line treatment, and also other options like an early referral for lung transplant. We have also to look at comorbidities because they can, of course, influence. They can have an influence in prognosis. Although, as you know, there is a low specificity and sensitivity in biomarkers, the definition of these comorbidities, but they can change prognosis. So I think it's important to look at these biomarkers, at these comorbidities also. And also it is important to have in mind a need of having an holistic approach. So not only with the treatment of our disease, of the disease that we are facing, but also with the supportive measures, the symptoms, looking at the symptoms, and of course with the end of life care. There are already many things that we are aware, and we have already a substantial knowledge. But anyway, we are lacking information on markers or predictors of disease progression, namely at the moment of diagnosis, and of many other therapeutic issues that have to be more clarified in the near future. And one of the important focus are the studies on biomarkers, I think, for the near future. This is an interesting paper called Injustice. So this is the acronyms of it's not just idiopathic pulmonary fibrosis studies. And I include this paper just to show you how interesting we have to look at the acronyms, how the acronyms might be sexy and humoristic, like this one called Scientific, that means search for humoristic and extravagant acronyms and solely inappropriate names for important clinical trials. And this is one of the most recent studies on biomarkers that we have now ongoing. We have also ongoing, as you are aware, some clinical trials on a medication for non-IPF progressive fibrotic ILDs, not only with pirfenidone, but also with the immunosuppressive agents. And at the end, and I think it is important to conclude, that despite the similar results that we could find in the INBUILD trials or the INPULSIS trials on IPF or non-IPF progressive fibrotic diseases, it's important to look that the UIP pattern could be associated with a more rapid disease progression, something that is perceived also here in this slide, where you can see the mean annual rate of decline of FVC with a more trend mean decline in patients with a UIP pattern regarding other patterns. So at the end, and this is my last slide, it is important to give hope and support to our ILD patients for them to accomplish life as normal as possible. Thank you. And we can do this multi-choice question, Ali? No. Okay, it is for the end. Okay, so it is now for you to answer. So my multidisciplinary my multiple choice question is the following. So regarding progressive fibrotic ILD, please choose the right answer from these 4 possibilities. It is usually possible to predict the fibrotic progression at the moment of diagnosis. So this phenotype has no impact on therapeutic options. It is a common pattern in all the idiopathic interstitial pneumonia. And finally, there is no single definition of fibrotic progression. You can vote now. That's fine. I think 3/4 and choose the right answer. So I'm satisfied with the result. Thank you. So maybe we can move to the next presentation, and it is my great pleasure to introduce you Maria Molina Molina. I wouldn't need to introduce you Maria Molina Molina. She's a very well-known pulmonologist, an expert on ILD from Barcelona in Catalonia, and she's working in the Bellvitge Hospital, and she will be very soon. She was recently elected chair of the group 12.4, so the rare interstitial lung disease group, and now she's going to present a hot topic on impact of COVID in ILD. Please, Maria.
Thanks, Carlos, and good afternoon, everyone. It's a pleasure to be part of this webinar. These are my conflicts of interest. For the next 15 minutes, I'm going to talk about the impact of COVID in our ILD field, especially with 2 main aims of objectives. The first one related to the COVID-19 infection when affecting ILD patients, and the second one related to persistent interstitial lung changes after the acute phase of a severe COVID-19 case. What we know now is that the ILD patients are not more frequently infected than the global population, probably because different facts. The first thing is that ILD patients protect themselves more than other patients. Probably the second one is that we as physicians try to avoid the hospital visits for our patients from early in the beginning of the pandemic. But we also know that when our ILD patients are infected with COVID-19 and require an hospitalization, the mortality in these cases is higher, as you can see here in the percentage of cases in this interesting and quick study that was led by Gisli Jenkins, comparing the impact of COVID infection in ILD patients hospitalized compared with the global population. And as you can see here, the more frequent entities were IPF, CTD, ILD, CPFE, and UILD. But one important point is that the worst survival for all the fibrotic cases were the lower FVC in the last spirometry before hospitalization. And the other point was obesity. An interesting point is that although 30% of cases were IPF, only 20% of them were receiving antifibrotic medication before the hospitalization. And for the third message, I will introduce this message through a real case. And this is a 59 years old male that we were following up because of fibrotic hypersensitivity pneumonitis. And as you can see here in our last CT scan from the last November, he presented mild reticulation with traction bronchiectasis, bilateral with no clear gradient, and also with air trapping. And he was diagnosed in 2017. So after avoiding the exposure and low dose of corticosteroids, he was stable for a long time. And we evaluated him again last July 2020. And we found a patient with dyspnea with mild exertion, with oxygen requirement only for walking, and with this CT scan. And as you can see here, the fibrotic changes increased a lot. And in the middle, what happened was a COVID-19 infection in April 2020. The patient required hospitalization because respiratory failure with bilateral pneumonia. And this is the chest X-ray. He required non-invasive ventilation. He didn't require intubation. And he received a high dose of corticosteroids followed by low dose until May. However, he required ambulatory oxygen, and he came again to our outpatient clinic because he presented severe dyspnea. The fourth point is that similar than in other viral infections, with the COVID-19 infection, we've identified subclinical cases of ILD, like in this case. This is typical. Every winter we are facing this type of subclinical cases that after a viral infection, we can diagnose an ILD. And it's a debut with an acute exacerbation. In this case, it was a non-specific interstitial pneumonia. And in this case was easy because we could assess the previous chest X-rays. And we found reticulation in this chest X-ray, so it was easy. If we have no previous radiological studies, we can use the first in-hospital high-resolution CT scan, looking for fibrotic signs. And here my question for introducing the second part of the talk. What do you know about persistent interstitial radiological changes post-COVID-19 in a normal subject? These abnormalities spontaneously are recovered. I didn't see these persistent changes. I've never faced these cases. The chest X-ray is enough for assessing post-COVID-19, or post-COVID-19 interstitial changes are very variable. You can, Ali, can you put a question? Here you are.
So you can vote. We cannot vote.
Can we see? Okay, so great, because I see that most of you are involved in the follow-up of these cases, and you could face this type of patients, and you agree with me that, of course, we are facing a huge variability of post-COVID-19 interstitial changes, which is awful for the patients, but it's an opportunity for the ILD field. I guess that, of course, the CT scan in the late phase of the acute phase, or even when after patient discharge, is very important for assessing these interstitial changes. And regarding the interstitial changes, we have to think about 3 potential pathways. The first one is the way that the virus is using for internalizing the cell. We know that coronavirus is using the ACE2 enzyme, one of the receptors of ACE2 enzyme, for going into the cell. And this ACE2 enzyme is very important in the lung for metabolizing ACE2 and ACE1, which are very pro-fibrotic potential peptides in the lung, and converting to ACE17, which is an homeostatic peptide that recovers the epithelial cells. So when this enzyme is decreased, like in aging people or in IPF patients, the ACE2 and ACE1 enzymes are increasing in the lung, ACE1 and ACE2 peptides are increasing in the lung, and the profibrotic cancer may be induced. And here, as you can see here, a collateral factor that could happen in COVID-19 infection is this induction of profibrotic cancer. The other 2 points are, on one hand, the acute respiratory distress syndrome induced by viral infection. Like for other viral infections, it's very well known that reaction of the lung in terms of diffuse alveolar damage or acute fibrinoid organizing pneumonia induced by different viruses, and also by coronavirus. And the other important point is the lung damage associated to mechanical ventilation. And we can identify these patients because there is a high, because it is more difficult to decrease respiratory support in these cases. And what is happening in these cases when we perform a lung biopsy is that histologically they present alveolar damage and collagen. And here you can see a typical case after 60 days of the acute phase. Usually, we use low-dose prednisone maintenance, reducing progressively into 4 weeks, and also starting respiratory physiotherapy. I have to say that in most cases, we can see an improvement of this type of changes over 4-8 weeks. And as you can see here in this case, there are predominance of ground glass opacities. But in last June, Ganesh Raghu and colleagues published this recommendation about the follow-up of the lung recovery after COVID-19, because we started to find this type of interstitial lung abnormalities, and we didn't know how to manage them. And not only cases with ground glass opacities, but also this type of cases with predominant fibrotic changes after several weeks of hospital discharge. And in this case, the oxygen desaturation during the walking test was persistent, and also the dyspnea on exertion. And in this case, we reviewed the previous medical history, and this patient had no previous lung disease. She was a 55-year-old female, medical doctor of the emergency room in another hospital. She was infected in March, hospitalized for 2 weeks and 3 days in the intensive care unit with mechanical ventilation. And after the hospital discharge, she couldn't work because of dyspnea with minimal activity. And they started the study. And when they found this type of fibrotic changes, they sent us the patient. We don't know yet the potential recovery over time. We are following the patient, and she's now under clinical trial. The clinical trial was designed because we thought that similar than what happened in the acute phase of COVID-19, maybe in the post-COVID cases, we could require an additional treatment. And we started using antifibrotic drugs in a clinical trial. And the idea with this clinical trial was if we could prevent the establishment of this induced fibrosis. Also because other ILD experts were looking for these potential benefits of antifibrotic therapy in the prevention of severe acute lung injury induced by COVID-19. And this was one of the first studies published, one excellent perspective from George Arthur Wells and Gisli Jenkins. And this is the clinical trial that we designed, and it's a Spanish clinical trial, multi-center, randomized and blinded, evaluating pirfenidone on the effect of pirfenidone on fibrotic signs induced by COVID-19 infection, evaluating the FVC decline and also the changes in the fibrotic stent. We are including patients with more than 5% of fibrotic changes in the CT scan, with or without corticosteroids. We are allowing a maximum dose of 50 milligrams per day of corticosteroids in this case. But also there is another clinical trial in France, led by Paris, by the group of Bruno Bresani, this time evaluating nintedanib versus placebo for 12 months. Regarding the FVC decline after 12 months. And they include patients with more than 10% of fibrosis in the CT scan. So finally, and in conclusion, we know that SARS-CoV-2 infection associates a worsening hospital survival in ILD patients and in global population. We also know that patients with pulmonary fibrosis that survive after COVID-19 may present disease progression. So we need to monitor our ILD patients after a COVID-19 infection, looking for a potential progression of the fibrotic disease. On the other hand, severe SARS-CoV-2 induces an acute lung injury that may present different types of persistent interstitial changes. And we know until here what is happening, but we need prospective studies and clinical trials for better understanding the potential interstitial sequela, because it's not the same persistent changes that a real disease induced by COVID-19. And probably in the future, we will be able to differentiate the persistent changes to the potential induced ILD. Thank you very much. And I want to reinforce the idea of working together, we can advance better. Thank you.
Yes, this is always an important message, Maria, and as all the message you gave us. Thank you for your excellent talk. And it is now my pleasure to introduce you, Marlies Wiesenbeck. I think it's good, well pronounced, Marlies.
Absolutely.
Thank you. And another well-known ILD expert from Netherlands. She's working in leading the ILD team in Rotterdam, in Erasmus Hospital in Rotterdam. And Marlies was recently also elected. So I have two new chairs here in the panel. Recently elected chair of the group 12.1, so the idiopathic interstitial pneumonias group. So Marlies, your task is to speak about the home monitoring. I think it's an important and very actual situation for us. Please.
Thank you, and thank you for the invitation. It's a real pleasure to talk about this, and I know that your group is also very much active in home monitoring, so a real pleasure to talk. I took the liberty to make the title a bit broader because I think it is a bit farther than patients with IPF, but also patients with ILD. These are my disclosures. And I would like to start off with a question to all of you, because we know that COVID changed our care models. And I would like to ask you, did COVID-19 change your practice with home monitoring of patients? A, I did not use home monitoring before and I still do not. B, I started using home monitoring. C, I continued to use home monitor like I always did. I increased my use of home monitoring and I would like to start home monitoring, but have not yet. And home monitoring in the broadest sense of monitoring patients outside of the conventional clinical setting. Please vote. Can I have the results? Because there's no wrong or right in these answers. I think it's quite diverse, but what is striking is that there's only a minority that didn't use it and still doesn't, and that there is a significant group of people who, about half, who either increased the use or would like to start. So I'll try to give you some updates on how the things are. And the three aims I have is to briefly touch on the impact of COVID-19 on monitoring patients, but I think you're all experiencing that. I will focus on home spirometry experiences so far, and I will talk a bit about the home monitoring future opportunities and challenges in a broader sense. I think we all recognize this. The elderly guy with IPF struggling with his oxygen, the COVID mask, the fear of coming to your clinic. But why does he come? Because he wants to talk with you and he wants to have his pulmonary function measured to know how his treatment is going and how decisions should be made. And I think currently there are multiple barriers. We have capacity problems in the pulmonary function departments. We have travel restrictions. We have hospital restrictions. It's a vulnerable population, like Maria said. They rather prefer to stay inside. And there's an extra demand on our clinics to see all these post-COVID patients to monitor them. But we also know that FVC and DLCO are important outcomes to guide our diagnostic trajectory and also our management decisions. So altogether, we have a threat currently in access to diagnosis for patients, access to care, and research in ILD. And this is just very briefly, I have no time to go into, but I recommend you to read the ERS recommendations on how to use with the aerosols and lung function in the current COVID era. And is home spirometry the solution for this? And here you see a patient blowing at the hospital, and here practicing with his home spirometry with his wireless connected to his tablet, where he could actually also generate measurements himself. So what do we know so far? The first time home spirometry was used in ILD and IPF in this time was by the group of the Brompton Hospital, Anne-Marie Russell and Toby Maher, and they showed that you could reliably get lung function and a curve, and that this curve actually probably in some incidences works better than in the hospital, because if you would see the patient at the red dots, you would assume that the course is like this, but it is the other way, it is declining. They also showed that you could see actually exacerbations and acute deteriorations, and they showed that the home spirometry in the first 3 months predicted mortality as 2 years. So a very important study. After this, there have been more studies showing that home health spirometry FVC correlated very well with in-hospital FVC, and that there was limited variability of about 3.8% in FVC measured at home, which is comparable to what we see in clinic. So there's good agreement with the in-hospital measurements. But then we had all kinds of stories that what is the impact on patients, especially in IPF, where you have a progressive disease, and what if the patient sees this lung function day by day? Many people were saying this is an elderly population, they won't like it, they will get scared, and their quality of life will deteriorate. So that's why we did in the Netherlands in 4 centers a randomized trial where we randomized patients with IPF that were about to start on medication to standard care plus home monitoring and standard care alone. And the primary endpoint was quality of life measured with the Kingsbrief Interstitial Lung Disease Questionnaire at 24 weeks. And what we showed is that overall, there was no improvement in quality of life, but if you would look on the psychological well-being, there was a significant improvement, and that also reached the clinical meaningful change. The breathlessness and the chest symptoms stayed more or less the same, which you would also expect, but the patients did feel better, and the patients also liked it a lot. Their experiences were very positive, and they would like to continue and recommended it to others. And besides that, we also found that we did more medication adjustments. So the medication was more tailored and there was no increase in anxiety and depression. What we also showed that you reliably could measure the trend in FVC. So the red dots are the in-hospital measurements and the gray dots are the home measurements. And you see that they are in good agreement. And remember this because I will also show you other data. And in the same time, there was another study in the US looking at the feasibility of doing home-based mobile health measurements. And also they showed a good correlation between home-based and in-clinic FVC. But what they found, and here you see the different curves, is that the trends through time did not correlate very well. So the blue lines are in hospital, the gray lines are at home, and I will get back to that. Another trial which was done, it was a biomarker trial, but it also included home spirometry, showed that there was very good adherence over time. So even after a year, 86% of patients was still doing this. And again, they showed good correlation between home and clinic measurements. And then there were two trials that for the first time used home spirometry as a primary endpoint. And I think this design was quite innovative. It was designed before the COVID times, but it actually gets more important, I think, in the current times. This is with patients that came into a local clinic with suspected ILD or IPF. They would be handed out a spirometer and an accelerometer, so a wristwatch with a step counter. They would do measurements at home. This would be loaded wireless onto a patient tablet. This patient tablet was connected to a collaboration platform where the tertiary expert center could see the data and the community center could see the data. The community center could upload their CTs and clinical data, and you could have a virtual MDT incorporating disease behavior of the patient, data from the second clinic, and expertise from the tertiary referral. And what this showed is that actually already in the peri-diagnostic time, there was a difference in decline of lung function in patients with IPF and non-IPF. And this was measured both at home as well as the site. And here you see these curves, and you see also, which is striking, that the time to diagnosis was quicker in IPF than in non-IPF, which again shows how difficult diagnosis sometimes can be. And this data we've already seen, the pirfenidone in unclassifiable that failed the primary endpoint due to technical issues. And here you see one of these technical issues, an implausible value of almost 36 liters on an FVC. This has to be taken into account because it was not set up front with how to deal with outliers, but that is a flaw of how we deal with these things. And also, Carlo alluded to that. For instance, if you have a patient with very limited numbers, one such an outlier is completely determining the cause. So we have to set rules on how to deal with these things. And those rules we have not unanimously agreed on yet. And then as the last part of the talk, I would like to touch on the future opportunities and challenges. And this is the two things that I already showed you. Why was this trend reliable in 4 centers and this in a multi-center study not? I can be very easy and say this was the Netherlands and that's the US, but that's actually not true. The patients were not blinded to their data, so they could actually get feedback real time on how their loops were and how they performed. And I think we should not underestimate patients. After a few times, they know how it works and they know how to do it. These patients below were blinded, so that you see that the quality of measurements gets worse then. And I would like to show you one of the other things that I think helped. We designed a system together with patients. So we did multiple rounds of their input, which I think increases the usability, because it's not always what I think also works for someone who is 75 and has a different background. And to make it more clear, I would like to show a small movie where one of the patients tells how it works. I'm not sure if the sound can go on. Ali, can you help me with that?
We dachten, hoe kunnen we de zorg nou verbeteren voor mensen met IPF? En daarom zijn we IPF Online begonnen. Waarmee we als het ware het ziekenhuis naar de mensen thuis brengen en mensen thuis gegevens kunnen verzamelen en metingen kunnen doen.
We hebben het programma echt samen met patiënten ontwikkeld. Na de eerste versie hebben patiënten dit getest. Vervolgens hebben we hun suggesties weer aangepast, hebben patiënten het opnieuw getest en zo is het uiteindelijke programma ontstaan. Patiënten meten thuis hun longfunctie op een draagbare longfunctiemeter via een app. Dat doen ze op hun tablet of op hun smartphone en dan sturen ze met een beveiligde verbinding hun gegevens door naar IPF Online. Ook vullen ze wekelijks online in of ze bijwerkingen hebben en hoe het gaat met hun symptomen. Als de longfunctie achteruit gaat of als patiënten hinderlijke bijwerkingen hebben, krijgen we daar als zorgverleners een automatische e-mail van.
De ervaring die ik nu heb is, er is iets, ik heb een vraag, ik zit ergens mee, altijd aan mijn ziekte gerelateerd. Ik doe een e-consult, ja, en meestal binnen een uur of binnen 2 uur krijg ik een reactie. En dat ervaar ik dus als zeer positief.
We hopen hiermee dat we uiteindelijk patiënten beter kunnen begeleiden. En we hopen ook dat we de zorg efficiënter kunnen maken, zowel voor dokters als voor patiënten.
Het grote voordeel van IPF online, zoals dat ik het ervaar, is dat de communicatielijnen tussen arts en patiënt, die zijn heel erg kort. Gevolg daar weer van is dat als er iets is op een gegeven moment dat ik me niet goed voel of niet lekker, of dat de resultaten van de testen die ik dagelijks richting ziekenhuis doe, daarom vragen, dat er direct vanuit het ziekenhuis gereageerd wordt, eventueel medicijn of medicatie aangepast wordt. En ja, daar voel ik me als patiënt daar heel happy bij. De extra tijd eigenlijk die ik zowel door minder ziekenhuisbezoek, omdat het thuis vandaan gaat, daar krijgt, die besteed ik graag bijvoorbeeld aan mijn hobby biljarten.
I think he explained extremely well how it works. I just quickly share with you what we see on our side. Here we see, for instance, a patient with a chronic HP that had an infection and recovered. We see the lung function going. Here we see the quality of life the patient scores. We see these symptoms and side effects, and we can do video consultations. Here you see a patient at home. So this makes your consultations rather efficient because you already know where the problems are with the patients. So it actually doesn't cost much time, but it yields time, in my opinion. So to sum up, I think there are many advantages for care in ILD. There's less travel for patients, it bridges distances, there's continuity of care in the COVID era. It helps patients to become empowered and get insights. You can closely monitor patients. You can use this for multiple healthcare providers. It is, I think, useful for safety monitoring in trials. It's not yet ready for primary endpoints. And we're working on a patient-led and field registry currently. But there are also challenges. What is the effect on care and outcomes? Ideally, you would do a randomized trial where you replace the visits, but we cannot do that in COVID times. What's the optimal frequency? The optimal alarm settings? Does it promote equal access, or do you disenfranchise patients that don't have internet? Is it fit for all patients, and importantly also for all doctors? There are legislational issues and reimbursement issues. And I just want to conclude with the last 2 slides, that we also used it now in home monitoring post-COVID infections to discharge patients earlier from the hospital because we could monitor them. And here you see a patient that was discharged at the 25th of September with a lot of cough complaints, low saturations, and you see through time that the patient does improve, and you see that the numbers get better and the patients get this visualized with balloons. And you also see that the lung function increases. This is the FVC. But we know that if we see them back at 3 months, the DLCO often lags behind, which has also been published in the AREA. So in conclusion, I think the COVID-19 era forces us to consider new care models to continue care and research for ILD. Home spirometry is feasible and reliable for regular care and safety monitoring in clinical trials. It empowers patients to become a partner in care and research. Technical, analytical, legislational challenges still exist, but I think these can be overcome. And we need more research to optimize and integrate this in care, but I think all possibilities are promising. And I thank you very much for your attention.
Thank you, Marlies, for this excellent presentation. So I think we have still some time for discussion. We have 3-4 minutes delayed, but we had a lot of questions. I think maybe I can start with questions for all of us, one by one. So maybe I will answer the first. The question was based on if I can anticipate a future without IPF in the scenario, without the definition of IPF, only of pulmonary fibrosis. I think I will be retired at that time. This is my first part of the answer. But I think it is true that we are needing a revision of the classification of interstitial lung diseases. For instance, the idiopathic interstitial pneumonias. I think it's not acceptable to have smoking-related diseases in the idiopathic interstitial pneumonia. So, or either they are idiopathic or related with smoking. This is one. But I see, yeah, and I think the future is getting more and more involved in looking at the pulmonary fibrotic progressive phenotype. But I think we have to look at the background, because it might be important for instance, therapeutic options. Might be important if the patient had a primary hypersensitivity pneumonitis or connective tissue diseases, or on the basis this was a idiopathic situation that we are calling now IPF, because we can use either immunosuppressive in the first two options and no immunosuppressive if we have a background of IPF. So I think I cannot anticipate a future where IPF do not exist anymore, as it was asked. But I can tell you that I think we have to look more and more deeply into the pulmonary fibrosis phenotype, and focusing on that also in a therapeutic purpose. And so I go now to Maria, because there are many questions related with the timing of introducing antifibrotic molecules in the post-COVID fibrosis. So some asking if we should we need to see fibrosis to introduce antifibrotic in these patients, or are there biomarkers for where we can? I think no. The answer is no, where we can sustain to introduce that, or should we do it along with steroids, or wait for the first usage of steroids in the first weeks of treatment, and then after that antifibrotics maybe? So it is about antifibrotics in post-COVID.
It's a very tricky question, Carlos, yeah. And probably there is no great answer. Maybe in the future we will be able to answer it better. But from my point of view, what I understand as irreversible fibrosis is honeycombing. So my point of view is trying to include antifibrotics in fibrosis post-COVID before having honeycombing in the CT scan, which is the only thing in fibrosis that is completely irreversible, because we know that even in some other ILDs, when you find reticulation, traction bronchiectasis, these two fibrotic signs may be reversible or may improve with the treatment. Honeycombing never improves. So my first advice is to try to start as soon as you see predominance of fibrosis, and avoiding to wait until honeycombing appears. If we have to use it during the hospitalization in the last phases of the post-acute phase, the answer is not, there is no right answer, because there are no clinical trials and no prospective studies. But I know that we are using some antifibrotic medications for patients in the intensive care unit that present fibrotic signs. So probably with more experience, we will be able to answer better.
Thank you, Maria. Marley, so also some questions for you. I can link some related with the time and resources that are needed for as well as all our normal work for this telemonitoring, and related with that, if it can be more useful in close to reference centers, or in more rural situations, more far from referral centers. I think it can be important. And also, if you can define, or if you can look at less emergency or healthcare usage of the patients as something to convince the hospital administration to invest in spirometry at home?
Yeah, I think those are all excellent questions. And ideally, you would do a randomized trial where you replace half of the care by home monitoring, look at all these factors. I think it is most promising for patients that live further away and are less mobile or use oxygen or depend on their children, because that obviously saves them hospital visits. To set it up, it takes a bit of time, but in COVID time, we already learned patients to do it by phone with a help desk where there's just a technician. So it will not weigh on the nurses or the doctors to set it up. And in the end, now for my video consultations, it saves time, because I already see where the problems are, because I already see if they have side effects, I see how their symptoms are, how their mood is, I have their lung function. So you already identify the problem and you can have a very directed conversation. I don't think home monitoring will completely replace face-to-face talks, because some things we're just not yet used to do online. Maybe we're forced to get because of the COVID, but I hope not. But I think it is a nice addition, and patients like it a lot. You see it in the satisfaction of the patients, because traveling 4 hours to see me in clinic for 15 minutes, having your son taking a day off, that is quite a burden. And if you can replace that in half of the times by a video consultation from your own couch, which has the same quality, I think is a benefit.
Yeah, thank you. So maybe we can answer quickly 2 very quick questions. Also, for me, regarding the silicosis and the asbestosis, included or not included in the clinical trials on non-IPF ILD. I'm not aware of that. I can anticipate that those patients were not included in the unclassifiable, of course, in non-IPF ILDs. At least to my knowledge, I don't know if you have some data on that, but I do not.
I don't know if there are very few in this REST group, but I know that, for instance, in Germany, they try to do a trial with this, and that many of these patients don't qualify for the progressive criteria. Yeah. So if they're in, it's very few.
Okay, so Maria, the usefulness of ultrasound in COVID ILD involvement.
Well, I guess that at least for the acute phase, it is a technical support very useful for us, trying to avoid the movement of the patient, and it's something that, depending on the type of lesion, for example, at the beginning of the acute phase, the correlation between the CT scan images and the echography is very high. Then for the follow-up, in terms of discharge, it's better to follow the patients with the CT scan, because interstitial changes are not very well correlated with the echography. But in the acute phase, yes, it's a very good technical support.
Yes, Maria, I think this is an important question, because we had more than one question on organizing pneumonia post-COVID. So you see that frequently? Did you see that frequently? Should we use steroids? Is there a benefit for that? And
at the beginning of the pandemic, we tried to understand better what was happening. So we performed some transthoracic biopsies after the patient died, so we could understand the histological part of this diffuse alveolar damage, and we found areas with organizing pneumonia, areas with acute fibrinoid organizing pneumonias, and also some collagen deposition with fibrotic areas, but without honeycombing, histological honeycombing, or fibroblastic foci. So in the follow-up, we had no histological sample, but I know that the group of Poletti and Sara Tomasetti have been working on performing transbronchial lung biopsies in these cases, and they will show us in a paper probably in the future what is happening in these cases. But I guess that the idea is around organizing pneumonia, a FOB, and NSIP.
Okay, so Marlies, how expensive is the equipment for a patient and for the clinic? And if you recommend the home daily spirometry measurement, having in mind the anxiety that can provoke to the patients looking at small changes day by day?
It's not that expensive. It depends a bit in which country you buy it, but it's between 80 euros and about 150 euros. And the yearly subscription for safe data hosting is 15 euros per patient. So if you do it in bulk, you're around 100 euros. If you set this off to the money that the antifibrotics costs and that you can tailor those better, I think it is an acceptable thing. The investment of the meter is one time. We replace them after 3 years. We don't know how long they still take. And what was the second question?
The second question is to do the home daily measurement regarding the anxiety, the possible anxiety.
Yeah, it's once a week, 3 blows, and the best is sent through works actually best than doing it every day. The patients like that at best, and we get the similar curve. So once a week is enough.
Okay, looking at frequent measurements, and I think we are sharply on time. Maria, how frequently should we do imaging to monitor post-COVID sequela?
Well, we need to individualize by patient, but at least we need one CT scan after the acute phase, and then we can follow the patient after 6 months. At least in our clinical trial, we have one CT scan in the hospital, in hospital, another one after the discharge, 2-3 months after discharge, and then another one at 6 months. And it's very important to remark that most of these cases will improve with corticosteroids. So we need to understand which patients could benefit from antifibrotic treatment, yep, and which ones may improve with corticosteroids for a longer period of time, 2-3 months.
Yes. So I think there are many questions. We are running out of time now, Ali. I don't know exactly what can we do, but I think we should. We could stay for.
We can take another question and then we close.
Okay, I think this is I think this is an easy question that maybe we can all answer together. If there are any markers, biomarkers that can predict fibrotic ILD after COVID-19, I would say no.
No, but I could say that probably familial history, yeah, of interstitial abnormality.
We lost Maria.
Yes.
I think she wants to say that they are at risk for developing abnormalities.
Could be an
yes, we couldn't listen to you, Maria. So the familial history, you were.
Yeah, I said that the familial history of the patient, if they tell us that someone in the family had ILD, some type of ILD, the probability of presenting lung fibrosis after COVID is higher. But regarding biomarkers, we will see in the clinical trials probably.
Okay. Do you want Maria and Marlies to say something else? I think we are almost 5 minutes on delay, but I think it is.
I can only say that if people still have questions, happy to email ERS or email me directly. I'm happy to answer them because yes, I saw many questions coming, and I'm very happy to take questions.
Yes, there are a lot of questions that maybe Ali, you can take care of that for us to answer. Maybe, is it possible? Ali?
Yes, of course.
Yes,
we collect those.
Okay, because we have a lot of questions. I could continue asking you questions, but I think it would be we would use more of the time that we are we should use for this meeting. It is 1 hour meeting, and I think first of all I have to thank the the organization. Ali, you were fantastic, helping us technically and supporting all the technical issues from the ERS office. Ali Mazouk, thanks a lot, and to all the ERS office. Thanks to the excellent speakers, Maria and Marlies, that we could enjoy your fantastic speeches and talks in the last minutes. And I have to thank all the audience. It was more than 200 people that we had here, and with a huge quantity of nice questions. Sorry that we couldn't answer all the questions, but I think we can do at least some of them. We can do that afterwards if Ali, you will send us the questions, and then we can answer some of your problems. So thank you so much for everyone that we could not see, and for the speakers we could see. Thank you again, Maria. Marlies, I think I would like to wish you a Merry Christmas, a safe and Merry Christmas, and a Happy New Year to all of you that still are listening to us, Ali, and all the audience. I hope that you stay safe until next year, and we will meet each other very soon, face to face. I don't know when, but maybe after the first semester we can do that by sure, hopefully. Bye-bye to all of you.
Thank you
Bye-bye.
very much.
Thank you.
All the best.
A better new year for
Bye-bye.
everybody.
I hope so. I hope so.
Thank you. Bye-bye.
All of us.